Good evening and welcome to the second day of Virtual ID Week organized by Federation of Clinical Pharmacists of India. I'm Dr. Alia Salim, clinical pharmacist at Apollo Cancer Center, Chennai. I'm also an infectious disease forum member of the FCPI. So today's session theme is AMS from a different perspective. So before we begin, I would like to go through a couple of things. Participants, you can post your questions in the comment box below the video thumbnail, and also a feedback form will be sent to your registered email address. So make sure that you submit it, and you can download your certificate within 10 days of submitting the feedback form. I think that's it. Without any further ado, I would like to welcome our first speaker, Dr. Umang Agrawal. Yeah. Dr. Umang Agrawal, he is an infectious disease consultant at PD Hinduja Hospital, Mumbai. He secured international training fellowship in infectious disease and general medicine through the Royal College of Physicians at Edinburgh Hospital, Cambridge, UK. He was awarded MRCP and diploma in UK medicine practice during his tenure in the UK. He completed his training in FNP infectious disease from PD Hinduja Hospital, Mumbai. He secured his diploma in tropical medicine and hygiene after completing the Global Health and Humanitarian Medicine course through Medicine San France Frontier, India, in collaboration with MSF UK. He was also awarded a fellowship in infectious disease from Hinduja Hospital. It's my pleasure to host you, sir. Over to you.
All right. Thank you, Alia, for those very kind words of introduction. And at the outset, I would like to thank FCPI for inviting me to give this particular talk on rapid diagnostics in the ICU. I'll just start sharing my screen. Yeah. So is my screen visible?
Yes,
Alia, my screen is visible?
yes.
Okay, so basically, this particular talk was to understand how rapid diagnostic tests in our ICU may be employed in promoting antimicrobial stewardship practices. And if you actually look at the entire array of instruments available for use, they are in plenty. So you have the RMT, RDT, Binance, Tropical Fever Panel, blah, 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 lots and lots of them. Now, this particular topic itself warrants a conference altogether. But of course, I've been given 30 minutes, so I won't be able to do justice if I discuss each and every one of them separately. So the talk of this, this particular talk will be focused on three main tests this way. That would be the beta-D-glucan, galactomannan, and BCID2. And at last, in case we have some time, I would like to go through a case wherein we had employed a rapid diagnostic test in the unconventional way for arriving at a clinical diagnosis and for our management purposes. So let's start with serum BDG. Now, serum BDG is basically beta-D-glucan and a pan-fungal marker, generally positive in all kinds of invasive fungal infections, except in cases of mucormycosis, cryptococcosis, and in cases of blastomycosis. So each and every parameter that I'll be discussing will be in lieu with a few clinical case scenarios to basically make you understand the place of these tests in our clinical practice. So let's look at this particular case. This is a 51-year-old lady who's a treated case of parietal lobe abscesses who had recently stopped antiepileptics. She was admitted in ICU for fever, drowsiness, and seizure. And at the time, she was admitted in casualty. From there, they had sent the blood cultures and shifted her to ICU. Eventually, she was diagnosed as scar epilepsy, had no other real problems. And eventually, she was discharged directly from the ICU within 2 days. Now, 3 days after discharge, that is almost on the 5th day of sending the blood cultures, her blood cultures came positive for Candida auris. At this particular point, the patient has been discharged already, and we get a frantic call from the primary team asking us what needs to be done. So this is case number one. The second case is a 60-year-old male who was recently admitted elsewhere for necrotizing pancreatitis. He had prolonged ICU stay, had several antibiotics, and eventually was better on discharge. However, over the next 1 month, he started complaining of worsening breathlessness, and that is when they got an echo done, which showed a large aortic valve vegetation with valve dysfunction. The patient was commenced on some antibiotics and aortic valve replacement was performed. Given that the vegetation was large, the primary team had sent off a beta D glucan, which was high, but all the cultures were negative. And the patient was now referred to infectious diseases to ask us what needs to be done about this beta D glucan. So if you look at these two clinical case scenarios, the first case is a patient who really does not have any of the risk factors for invasive candidiasis, but she does have a blood culture positive for Candida auris. The second case has lots of risk factors for invasive candidiasis. She had an intra-abdominal sepsis, had received multiple antibiotics, has a large vegetation on the 2D echo. Antibiotics have been commenced, but the cultures are negative and the BDG is positive. So now in these two scenarios, I will try to actually depict how BDG helped us in both these cases. So a short note about beta-D-glucan. As I said that it is a pan-fungal marker. It can detect all invasive fungal infections except for Cryptococcus, Zygomycetes, and Blastomycosis, and it's a colorimetric test. An important thing about beta-D-glucan that you all should know is that it has a very high false positivity rate. So if the patient has been on hemodialysis, then probably not that much of a concern in the present scenario because the use of cellulose filters has reduced dramatically all across India. So probably this would not really be counted as an important false positive. But patients who have received IVIG, IV albumin, any other blood products, who have been on augmentin, surgical mesh, who have had a surgery in the past 3 days, and in certain bacteremias as well, it may be false positive. All right. So you also need to understand that if the patient has a high bilirubin, it can have a false negative result as well. Now, with this small background of beta-D-glucan in mind, let's go on to the first case. So when we had received the call for this particular blood culture, what we did was we just called the patient back in and we went through the entire history. The patient was well. She had no fever. She had no symptoms or signs of infective endocarditis, no other risk factors to suggest candidemia. And all her recent blood investigations were unremarkable. At the same time, we discussed this case with a microbiologist who said that this particular culture was also growing a cons. Now, given that all this is the case, this one of the inkling that we had was this Candida auris was probably just a contaminant. And sure, so what was the best way of proving that? We just sent off a serum BDG, which was negative. All right. So this is a case wherein you have a positive blood culture for an invasive, difficult to treat fungus, but with the use of serum BDG, we were able to avoid unnecessary antifungals in this particular case. The patient is doing quite well presently. All right. Let's go on to the second case. Now, this particular patient, as I told you, had lots of risk factors for invasive candidiasis. When we went to see her, the patient was seen on post-op day 4. The patient was well and was transferred out of the ICU. The surgery had gone off really well. And when we actually started investigating, we saw that the serum beta-D-glucan was sent 1 day post-surgery. Now, if you look at the causes of false positive BDG, one of the important false positive causes is if the patient has had a surgery in the past 3 days. So please understand. So this is how you need to interpret these reports. And why does that really happen is because whenever you have a surgery, the gauze material that you're using for the surgery has a lot of cellulose, which can actually give a false positive BDG. However, take the clinical context in the picture. This patient is, if you actually look into the aspect wherein we need to start antifungals or not, this patient has had a recent episode of necrotizing pancreatitis and intra-abdominal sepsis, basically, which is a known risk factor for invasive candidiasis. He had an Enterococcus faecium bacteremia. Rather, if when we actually looked at it, it was an Enterococcus fecalis bacteremia. I apologize for that mistake, which generally indicates to gut translocation. And he did have a large vegetation. So all these did support invasive candidiasis in these cases. However, what were the points against? You had 3 negative blood cultures despite the patient not being on any antifungals, which can happen, but usually not that common, especially in 3 sets. The blood culture positivity rate for candidemias is generally to the extent of around 40 to 50%. So we do expect at least the cultures, at least one of them should have flag positive. The patient was doing well, quite well clinically. He had no fever. And there was, of course, a possibility of false positive VDG. So at this point, what did we do? We decided to closely observe, wait for the final histopathology report to understand if there are any yeast seen in the histopathology, and we repeated a serum BDG. Now, this serum BDG was done on post-op day 6. Although we had seen the patient on post-op day 4, we had sent the BDG on post-op day 6. At that time, we were doing the BDGs every I think twice a week or something like that. And I think this was a Saturday when we had the reference. So we had to send the BDG on Monday, and voila, it was negative. So you have two cases here. One of them has a positive BDG but a negative culture. Here we did not give antibiotics given the clinical context. The first case, however, had no risk factors for candidiasis, but did have a positive blood culture for Candida auris, and that is where BDG helped us in ruling out the disease. So basically, what I'm trying to say is whenever you're using these markers, interpret these markers in the clinical context. Potential applications of this test. It can be helpful in diagnosis of IFI. It can help in the exclusion of IFI, as I told you in both these cases. And in certain cases can be helpful in assessing treatment response. But the bottom line is please correlate your results on a clinical basis. Okay? So this was as far as BDG was concerned. Let's talk a bit about serum galactomannan. So what exactly is serum galactomannan? Serum galactomannan is basically a molecule which is secreted by the growing hyphae of invasive mold infections. So when you have an invasive mold infection, which is the hyphae of which are growing into the blood vessels, the tip of that hyphae releases this particular molecule, and that is how galactomannan is present in the serum. However, what happens is if the patient has a decent neutrophil count, these neutrophils will go and attack this particular molecule. So if you actually look at it logically, theoretically as well, serum galactomannan in a patient with a normal neutrophil count or in a non-neutropenic patient may not be as high. It is not expected to be high. And which was basically this particular theory was substantiated by this evidence, wherein they found that the sensitivity of galactomannan in a non-neutropenic patient, especially for serum, was 30%, while in case of a neutropenic patient, the serum galactomannan sensitivity was 95%. If you actually look at the BAL galactomannan values on the other hand, now BAL, whenever we are doing, we are using the airway. We are basically collecting the fluid from the airway where you're not expecting any neutrophils. In those particular cases, the sensitivity of galactomannan in both neutropenic and non-neutropenic patients was 95%. All right. So with this small introduction of galactomannan in mind, let's go on to the next case. This is a 57-year-old gentleman who had diabetes, hypertension, and chronic kidney disease. In May 2020, he was diagnosed with COVID and eventually he was commenced on hemodialysis. Around a year later, he underwent a renal transplant, had a stormy course in the ICU, received multiple antibiotics, had several bouts of sepsis, and eventually he recovered. And in December, he got admitted elsewhere with fever along with breathlessness, wherein they did an evaluation and found him to have aortic valve endocarditis with severe valve dysfunction. Again, this patient had multiple negative cultures and a CT chest showed fibronodular shadows. They had done a beta-D-glucan and galactomannan elsewhere, which was 255 and 1.8. At this point, you also need to understand that as with beta-D-glucan, there can be certain cases wherein your serum galactomannan may be false positive. All right. The patient was commenced elsewhere on meropenem, teicoplanin, and liposomal amphotericin B, but he was not improving, and on the basis of that, he was shifted to Hinduja. Now, if you only focus on the points highlighted in yellow, you will understand that a patient who has chronic kidney disease, who's post-COVID, has undergone a renal transplant, and who has fibronodular shadows. All right. So he is basically an immunocompromised patient with a high risk of an invasive fungal infection, with all the cultures being negative. Now, one of the concerns at this point was that whether we are dealing with an invasive mold endocarditis kind of a thing or not, because of all the things highlighted in yellow. Now, if you actually look at the CT scan, if you can appreciate these nodular shadows in both the lungs, predominantly on the right side. All right. So it was obvious that there is something going on. There's some kind of an invasive fungal infection going on there. What did we do? We just repeated a serum BDG and galactomannan. Voila. The serum galactomannan was 4.118 and beta-D-glucan was more than 523. This patient had not received albumin. All right. Now, as I told you earlier, that in a patient who's neutropenic, the sensitivity of serum galactomannan is quite low. However, a value of 4.118 for a serum galactomannan in a patient who's non-neutropenic is highly significant, especially in a setting wherein the values are increasing. All right. All his cultures which were sent at admission were negative. The patient was too unstable to undergo a BAL, all right, because of those fibronodular shadows. So despite all the negative cultures, only on the basis of the clinical history and these two markers, we were able to arrive at a provisional diagnosis of Aspergillus endocarditis. We optimized the antifungal regimen. The serial galactomanans on that started showing a reducing trend. This patient ideally required surgery, but he had so many impending issues going on. He was an immunocompromised patient. He had AKI, eventually developed embolisms. He had 2 or 3 episodes of cardiac arrest, and he was considered high risk for surgery. Unfortunately, because of that, he unfortunately succumbed. All right. So this particular case gives you an idea wherein these kind of biomarkers can give you a diagnosis in uncanny situations like these. Now, what are the important causes of raised galactomannan? It can be because of aspergillosis. Of course, that's the most common one. But please do know that it can be positive in other mold infections as well. So it could be histoplasmosis, schistosporiosis, Staphylococcus fusariosis, even in some dematicious fungi. Rather, so what had happened was that before we ever had the urine histoplasma antigen test, if a clinical suspicion for a patient was histoplasmosis, one of the ways of confirming it, of course, if we don't have the biopsy available, was a serum galactomannan, which used to be very high. Right? So that is how you use this particular marker in a clinical context. Important causes of false positive galactomannan are piperacillin, tazobactam muse, usually the generic brands, and augmentin. All right. So that's that about invasive fungal markers, BDG and galactomannan. Let's talk a bit more on a BCID2 panel, multiplex PCR. All right. We'll start with the case and then I'll go through the BCID2 panel in detail. This patient was a 25-year-old male, known case of liver transplant. He had undergone a liver transplant and was started on steroids, MMF, and tacrolimus. He was on valacyclovir prophylaxis as well. And during the transplant, his hospital stay was uneventful. 6 months later, he was admitted with complaints of high-grade fever, chills, and rigors. On admission, he looked septic. So his pulse was 150, blood pressure he was hypertensive. He did have jaundice. And immediately after sending 2 sets of cultures, the patient was started on meropenem and teicoplanin, rightly so. The abdominal imaging showed evidence of obstructive cholangiopathy. So we are dealing with a case of an abdominal sepsis, severe abdominal sepsis. At this particular point, 2 cultures flagged positive for a GNB, and that is where we got a BCID2 result, which showed E. coli with no mechanism of resistance detected. All right. So how do we go ahead with this? Before we come to the answer, let's talk a bit about the BCID2 panel. It is basically a multiplex PCR assay which takes 43 targets and provides information on the organism and the genetic mechanism of resistance within 2 hours of the culture flagging positive. It facilitates earlier institution of targeted treatment. So imagine you get a GNB. It will take around 18 to 36 hours for your cultures to grow and for the DST to come in. So it will take around 36 hours for that to happen. Imagine if you can get the same information within 2 hours of the blood culture flagging positive. So that is how BCID2 may be helpful. And it can facilitate targeted treatment with potential impact on clinical outcomes and MSP measures. If you look at the targets, it targets important ICU bacteria. So if you have the Acinetobacter species, you have the Enterobacteriaceae, including the E. coli, Klebsiella, Proteus, and you have Pseudomonas as well. Important mechanisms of resistance include in gram negatives are all your carbaphenemases, which is detected by expert CARBAR as well. In addition, it takes MCR1, the colistin resistance, and CTXM. 85% of our isolates, ESBL producers are actually due to CTXM15, which can be detected by this particular panel. If you go on to the gram-positive panel, it detects Staphylococcus aureus, lugdunensis, as well as epidermidis. And it also detects MAK as well as MAK-MREJ, basically for MRSA. It also detects Enterococcus along with Van A, Van B. And it can detect around 6 or 7 types of Candida, including 6 or 7 types of yeast, including Cryptococcus neoformans. So it has quite a comprehensive coverage. However, it does not detect everything, and that is actually the bottom line. All right. Why is that important? I'll come to that in some time. Now, this particular study was performed by Siddhant. Actually, he had collected the entire data. He's my fellow currently at PD Hinduja Hospital. We wanted to understand the correlation of the BCID2 panel with phenotypic blood culture results in an Indian ICU. So we had 166 BCID2 results with 176 isolates. And we had made three definitions. One was the concordance rate of BCID2 with the phenotypic cultures. One was the failure rate. That is, the target was present on the BCID2 panel, but despite that, the BCID2 panel could not detect it. And we wanted to understand the limitation rate. That is, the BCID2 panel could not detect the target because that target was not really present on the panel. All right. What did we find? That for monomicrobial cultures, the concordance rate was 82%. All right. We had around 24 episodes of discordance, but the failure rate was extremely low, just 2 out of 177 samples, 177 isolates. Most of them were limitations, especially in the resistance pattern. Interestingly, what happened was BCID2 detected in two such organisms, it detected two organisms which were not really detected by the culture as well. So it detected it additionally because of its high sensitivity. Now, an important point that I wanted to put forward here was that in our Enterobacteriaceae isolates, wherein the CTXM was negative, 25% of those isolates actually turned out to be ESBL, possibly through a TEM or an SHV mechanism. All right. So even if your E. coli or a Klebsiella is not showing CTXM, especially in a patient who's sick in your ICU, do not try to come down from meropenem. All right. It could still be harboring an ESBL, at least in 25% of our cases in this particular study, at least. We had around 29% incidence of carbapenem resistance, and BCID2 was able to detect 87% of those mechanisms. So out of 46 isolates with carbapenem resistance, BCID2 detected the mechanism of resistance in 40 of those isolates. But what about the remaining 6 isolates? Well, they were carbapenem resistant non-lactose fermenters. So we know that for Pseudomonas, the main mechanisms of resistance are porins and effluxes, not really carbapenemases. So porins and effluxes, OPRD, OPRM, they are not all present on the panel. Neither are OXA23 or other non-OX48 oxas. So if your ICU has a problem more of with Acinetobacter or Pseudomonas, probably this particular panel might not be that useful. Now, after finishing up the study, we wanted to understand whether this particular panel would help address antimicrobial stewardship practices in our ICU. And on the screen, you have Dr. Saitulu and Dr. Saili, our excellent clinical pharmacists who are basically driving this entire project. They have been collecting the data diligently over the past 6 months, and we are hoping to analyze them soon and publish it eventually. This is the PICO. I'm not going to go through the details for lack want of time, but I have quoted the project code as well as the CTRN number if in case anyone is interested in going through this particular study. Now, coming back to our patient, this patient has an E. coli with no mechanism of action detected. He is on dual inotropes as far as I remember. And at this particular point, what might be the best antibiotic management? So we know that this is a gram-negative bug, so possibly teicoplanin can be knocked off. I would agree to that. However, I would be wary of de-escalating meropenem just on the basis of this. I would still want to wait for the phenotypic culture report to come in. All right. So eventually, this particular culture came out to be an ESBL E. coli. So this was one of those 25% of the samples which were actually an ESBL despite a non-CTXM. All right. So that is how we are using BCID2 in our particular setting. So again, to emphasize, whenever you're using a multiplex PC or any such panel, please understand the limitations of the panel and please look at the patient in front of you before you take any antibiotic decisions for you. It can really help in your antimicrobial stewardship practices as well. Important take-home messages for this panel. It has good results in monomicrobial cultures, not so much in polymicrobial ones. More useful in ICUs without non-lactose fermenters, as I've already mentioned. This you don't need to worry about. Know what your panel can detect, but more importantly, do know what your panel cannot detect. All right. So this is as far as BCID2 is concerned. Do I have around 10 minutes for this case? Okay, fine. I'll
We
just go
have
on.
10 more minutes for discussing questions.
Okay, fine. So I have 10 more minutes, right, to go through this case? Alia?
So 3 more minutes. I mean, yeah.
Okay, no, it started a bit late, that's why. Anyways, I'll go through this case quickly. Basically, it was a 45-year-old laborer from Akola, Maharashtra, who was recently diagnosed with AML and was admitted in ICU with hypoxia with these kind of lung lesions. Eventually diagnosed to have an invasive fungal infection, the bile galactomannan was high, and the culture through Aspergillus terreus. He was started on posaconazole, and good levels were ensured. And then he was commenced on chemotherapy 7+3 regimen, which is highly toxic and can cause prolonged neutropenias. His clinical course was complicated by subarachnoidal obstruction, febrile neutropenia, and was managed conservatively. But the odd thing was that after commencing the posaconazole, his respiratory condition had become better, but had now started deteriorating again. When we repeated a CT, it was horrendous, bilateral intense ground glassing with consolidates. So at this particular point, our differentials included heart failure, diffuse alveolar hemorrhage, possibly a PCP pneumonia, as well as viral pneumonias. We got the BAL done, which showed a PCP PCR positive, expert ultra was negative, cultures were negative, galactomannan was fine, and this patient did not really have a dropping hemoglobin, so diffuse alveolar hemorrhage was ruled out, and heart failure echo seemed to be okay. So the only thing that was left with us was a possibly a viral pneumonia. At this particular time, please understand that understand the clinical condition of the patient. It was D+15, wherein the patient is extremely neutropenic. If you look at the CBC here, the WBC count was just 100. Although he was not on inotropes, but you can understand from the CT picture as well that his FiO2 requirement was quite high, 100% at the time when we had come in. Now, interestingly, the BAL cytology showed these intranuclear molding, if you can appreciate that. And it was reported as viral infection, HSV, more likely than CMV. All right. Now, what is our clinical consideration? This patient is undoubtedly sick in the ICU, intubated with a high FiO2 requirement. The WBC count is 100. I really need to understand whether it's HSV or CMV. And why is that? HSV is treated with acyclovir, but CMV is treated with ganciclovir. Now, ganciclovir can also be used for the treatment of HSV, but the problem is it causes very bad cytopenias as well. And in a patient who has a WBC count of 100, I don't really want to subject that patient to ganciclovir unless I'm forced to. All right. At this point, although ganciclovir would work, as I've spoken about, if I order for a CMV PCR, it will take around 72 hours for that result to come in. HSV PCR is not really done in a setting. Even if I outsource it, it will take a week for the results to come in, which will be a long, long time. I really don't have the time to do that. I need my answers very, very fast. So now what do I do? Well, I use a meningitis biofire on the BAL sample. Now, what happens is the meningitis, the biofire meningitis panel that has HSV as well as CMV on it. So that can give me the answer within an hour and a half. And that is what I did on special request. Meningitis biofire was run on the BAL sample, which confirmed the diagnosis of HSV1. And I avoided the use of ganciclovir altogether. So basically, my take home messages for rapid diagnostics is know what your test detects, but also what it does not detect. Know when to use it and when not to use it. So, for a BDG, whenever you're suspecting an invasive fungal infection, if the patient has been on albumin, do not use that test. It's undoubtedly going to be high. You understand? So, just understand what kind of drugs or things the patient is on before you start using this test. And always interpret the test results with the clinical context. That is how it will optimize your management of the patient. And greetings again from Hinduja Hospital, Mumbai. This is our entire ID and clinical pharmacy, clinical pharmacist team, our entire antimicrobial stewardship team as well. Thank you so much.
Thank you, sir. That was really insightful. We have a couple of questions. Can you hear me? Sorry, there was some glitch. Sir, can you hear me?
Yeah.
Yeah, okay. The first question is, after how many days should we test for BDG so that it after post surgery, so that it will show positive or negative?
So if you actually look at the cadence, they say around 3 days, but we prefer sending it at least after a week, So it could be, so it depends also about how extensive the surgery has been, how much gauze has been used. But as a general rule, maybe around a week after surgery is when we prefer to send it.
Okay, sir. Next question is, what are the diagnostic biomarkers of sepsis in routine ICU practice?
Okay. So as I said, that BCID2 is one thing that you can absolutely use. Apart from that, you have the PCT, the CRP, which have always been very, very useful. Of course, they need to be interpreted in context of the clinical condition of the patient along with the creat. These markers can be high in that. But yeah, so these are the three ones. You need to understand that BCID2 per se itself is an expensive test. However, it can really, in our experience, whatever cases we have seen, it has definitely helped us in escalating the management quite a bit. So patient who has been on Mero and Tyco, we get an NDM. Either we change it to ceftazidime avibactam or this thing polymyxin. But it does offer an excellent opportunity to de-escalate very quickly as well, which can help in antimicrobial stewardship practices. There's another panel known as the sepsis flow, which I think is being used in other places, which has much more targets than BCID2, but each has its own pro and con. So sepsis flow, I think, as I understand, will require some technical expertise. It is a band-based assay, not FDA approved, etc., and all those things. But undoubtedly, it can be useful for the management of patients as well. So yeah, these are the various diagnostics available for sepsis, especially.
Okay. I think that's it. Thank you so much. I think it was really helpful.
Sorry, Ali, I can't hear you.
Can you hear me now?
Yeah.
Yeah. Thank you so much. It was really
No,
helpful. In the short time, you tried to clamp in so many informations.
sure, no problem. Thank you. Take care. Take
Thank you
care.
so much, sir.
Yeah.
Okay, sorry for the delay. Next speaker is Dr. Vikram Padvitri. He is a consultant and head of Department of Microbiology and Infection Control at Jahangir Hospital, Pune, with 20 years of experience. He completed his MBBS from Bharati Vidyapeeth Medical College, Navi Mumbai. His area of expertise includes bacteriology, immunology, mycobacteriology, infection practice, etc. He has an experience in PCR and hospital lab accreditation in NABH and requirements. It's a pleasure to host you, sir. Over to you.
Okay, thanks, Alia. Am I audible?
Yes, sir, you are.
Okay, great. I'll just try and see if I can share my screen with you all. Okay, PPT visible?
Yes, sir.
Yeah, okay, great. All right. So at the outset, I'd like to thank the FCPI and especially Dr. Saili for inviting me and also for giving me another difficult and offbeat topic. But I've had fun trying to prepare this, and I do hope that you all will also enjoy listening to what I have to say. So what we'll do is I'll go through this in 5 parts. The first part, I'll just try and tell you what the infection prevention and control people do. And I'm sure yesterday you'll have had very good sessions on antimicrobial stewardship, and you all probably know the roles of a CP very well. So I won't delve too much into that. I'll then try and look at how different are IPC and AMS and see if or how similar are they. And then we'll see if there is any overlap in the functioning of these two departments or sections. We'll try and look at if there is any data to prove whether they can work together or not. And finally, of course, I leave it to you all to take a call whether this can be mutually symbiotic relationship or not. So let's look at infection prevention and control versus antimicrobial stewardship teams. So the IPC basically deals with a reduction, or the main aim is a reduction in the healthcare associated infections that often plague patients who have been put on various devices like a ventilator or a urinary catheter or a central line, or I have undergone a surgery. The main focus is on prevention of all the infections that might arise from the placement of these devices. And we also look at surveillance, that is trying to look at whether what are the rates of these infections, what are the denominators, the numerators, and so on. We also look specifically focus on hand hygiene and many other things. We also look at biomedical waste, and finally, of course, training and audits. The CPs in a brief are usually looking at minimizing antimicrobial resistance in the hospital by looking at the antibiotics that are being given, whether it's in the right dose, the right route, the right duration of infusion, if there is, the de-escalation of antibiotics once the culture report comes in, any interactions with any other drugs or other antibiotics that are going on. And eventually both of them to a certain extent have a little bit of a role in training of the healthcare personnel, either in infection prevention measures or in measures to use antibiotics or other drugs appropriately. Coming to healthcare associated infections, I briefly described these, briefly alluded to these rather, didn't describe it. We have the device related infections, which is the ventilator associated pneumonia, or VAP, which is very commonly known as. This occurs in patients who have been put on a ventilator, and because of various reasons, these patients tend to land up with a pneumonia, usually with a bug that is prevalent in that particular ICU, and this is called as a VAP. Now, the diagnosis of a VAP was usually very subjective earlier because you needed a radiological features, you needed clinical features, and you needed microbiological features. But now it's been made a little more objective by using something called as ventilator associated events, where we look at the FiO2 and PEEP and decide whether it is a ventilator associated condition. If there is any infective component to it, like fever or WBC count going up or decreasing a lot, we call it an IVAC. And if there is treatment which is being given, then it comes in as a PVAP, or a possible or a probable ventilator associated pneumonia. So this is something that deals with the respiratory system. Coming to the urinary tract, we have something called as a catheter associated urinary tract infections, which usually occurs in patients who have a urinary catheter in place over a prolonged period of time. So not taking care of the catheter properly can cause cortes to come up. The next is the central line associated bloodstream infections, which occurs in patients who have got a central line in place. So depending on the site of the central line or the care that is taken, the kind of infusions that are given through the central line, there are various risk factors which can cause a patient to land up with a bloodstream infection. And finally, we have the surgical site infections, where people who are operated have an infection at the site of operation, either in the deeper structures or maybe even a superficial part on the skin. So these are all the healthcare associated infections that infection prevention and control looks at preventing. So the way they do this is through bundles. So these bundles are nothing but a collection of measures that, when done together, have been shown to be effective in the prevention of VAP, COTI, CLAPSI, and also SSIs. Usually in the ICUs, you would have a page which has all these components of the bundles, and a tick mark which is done in each shift, saying that you have followed whatever measure was required as part of that bundle to prevent that particular infection. So this all comes under the purview of infection prevention and control. Now, it's very important to know what your rates of infections are, because without knowing your rates of infections, you can never improve. So unless you have a number to a particular entity, you can't really improve or deteriorate in that entity, because you'll never know whether you're doing well or you're not doing well. So that therein comes surveillance, which is one of the most important roles that an infection preventionist or an infection control nurse does. So in the rates, we have a numerator and a denominator. The numerator is what I've just explained to you all about the pneumonia, the urinary tract infection, and the bloodstream infection, which is usually diagnosed with the help of clinical features and microbiological features like growths in the endotracheal or tracheal secretions, the urine growing some organism in a colony count of more than 10⁵, or 10⁵ in some instances for a catheterized urine if you look at the IDSA guidelines. And of course, the same organism growing from blood which has been drawn through a central line and from a peripheral prick in case of a bloodstream infection. So this forms part of the numerator. So you pretty much know I've got 1 VAP, I've got 2 COTIs, I've got 3 CLAPSIs or whatever. Now, the important thing here is the denominator, because the denominator is extremely important. You need to know the number of device days. That is the ventilator days or the urinary catheter days or the central line days. So this is where a bulk of the work of the infection preventionist is contained, where they look at collecting the denominator from all over the hospital and then compiling it over a period of time, usually a month. And then we have the numerator divided by the denominator multiplied by 1,000, because here we look at, for all these device related infections, we look at it as a per 1,000 device days. So one VAP will be whatever, 1 per 1,000 ventilated days. COTI will be say 2 per 1,000 catheter days, and so on. So these rates need to be presented to the involved stakeholders, which may be the ICUs, it may be the management, it may be the infection control committee, and so on. Once you have your rates, you have your infections, another huge headache that starts for the infection preventionist is an RCA as to how that infection occurred. So an investigation into what went wrong, were the bundles not followed, was the patient at high risk, did something else go wrong during the period that the patient had the device in place. So this is a big investigation by itself. And then once you identified a root cause, you go in and train all the people on not repeating that mistake, so that you, over a period of time, decrease your rates. So this is something that an infection preventionist does. Now, I'd just like to take maybe a minute and discuss hand hygiene, because no presentation on infection control can be complete without mention of hand hygiene. So hand hygiene, as you all maybe know, and if you all don't know, please listen, is the single most important tool in the prevention of infection. So if you can't do anything else, you can at least get your people to practice hand hygiene every time that they either touch a patient. After they touch a patient, we have the 5 movements. I'm sure you'll be able to reduce your infection rates by at least half, if not more. So we have the WHO 6 steps of hand hygiene and also the 5 movements of when you should be practicing hand hygiene. This is a part of the isolation precautions, which we will discuss a little later. Remember, each bed should have a hand rub. So this is something that is mandatory. The further away the hand rub bottle is from the person who needs to use it, less the chances that that person is going to end up using it. So the best place to keep that hand rub bottle is at the foot end of each bed or somewhere close by where it's within a couple of steps reach, or for a healthcare worker, whoever is touching the patient. So quickly, I'll just revise the 5 movements. One is before you touch a patient, after you touch a patient, before an aseptic procedure, after any potential exposure to blood or body fluids, and the last is after touching patient surroundings. Now, this is extremely important for the clinical pharmacists and for anyone else who's visiting the patient, because usually they tend to touch either the files of the patient, which are kept next door to the patient, the bed rails or the monitors, and they may feel that, oh, I have not touched the patient, so maybe my hands are not contaminated, but that's not true. Bugs like Acinetobacter, MRSA, VRE can be shed into the environment, and the area surrounding the patient can be contaminated with all these bacteria. Therefore, it's extremely important that you disinfect your hands whenever you come away from a patient. So if you've gone to a patient bedside to look at the file to see which antibiotic that patient is on, after you've finished, you're done with everything, please remember to use your alcoholic hand rub. Okay, the role of infection control and antimicrobial resistance. The goal is eventually to prevent the spread, to prevent cross transmission. There is something called as barrier precautions or isolation precautions, which we use for all the multi-drug resistant organisms like XDR or PDRs. So at Jahangir Hospital, what we use are, we've got signages for the 3 different types of isolation precautions, that is contact precautions, isolation precautions, the other isolation precautions like respiratory precautions of droplet and of airborne. So any patient, any person who goes in to see this patient has to use a hand rub when he or she comes back. There'll be no sharing of patient equipment. If any equipment has to be taken out from the patient's cubicle, then it has to be properly decontaminated. Wherever possible, the patient should get a single room and visitors should be restricted. So this is, in short, the barrier precautions or the isolation precautions that need to be followed. Screening is something that we have also started for things like MRSA and now recently Candida auris, because these organisms tend to spread very rapidly in ICUs and in hospitals. I spoke about bundles, the use of bundles for HAIs. So this is also something important. And once the patient is discharged, there is something called as terminal disinfection, which needs to be done to ensure that that bed and the surrounding area has been eradicated of all the multi-drug resistant bugs, whichever the patient was colonized with or getting infected with, so that the new patient who comes in does not get infected with all these bugs. So this is what the infection preventionist does. I'll just quickly show you all the effect that an infection control program and education program can have on the rates of isolation of certain bacteria and also on the HAIs. So this is something that we had done way back in 2008 when we had our first hand hygiene campaign. Now, since we were doing this for the first time, this was almost a month and a half long, which we had done in August and September of 2008, where we had lectures for the staff of the hospital, and we'd ensured that not more than 15 to 20 people attended those lectures. Now, what we had also done was that we had taken fingerprints on blood agar plates one day prior to the lectures. So what we did is we asked the people to put their fingerprints onto a blood agar plate, use an alcoholic hand rub, and again place your fingertips into the agar plate on the other side of the agar plate. And the next day, we used to show them the plates to show them that the part before a hand rub was contaminated with bacteria, whereas the part after using the hand rub was absolutely clear. This actually, we thought and we realized, made a big difference to people's acceptance of the need for hand hygiene. And this is something that you all can probably use in your hospitals as well. So if you look at the data, our MRSA isolates for 2008, we've got sporadic isolates almost 1 or 2 every month. And then suddenly, after we finished that hand hygiene campaign, 2 months we had 0 isolates of MRSA. If you look at the right side, the MDR Acinetobacter isolates also went down by almost half. So this was an immediate response that we saw. And ever since, we've been able to keep the MRSAs in check, but the Acinetobacters have had brief periods of increased isolations, and then they've gone down again when we have sort of potentiated or stressed on our infection control measures. If you look at the rates, our VAP rates went down by almost half for the next following 2 months. Our COTI rates also went down by almost half, and our CRBSI rates took a little longer to come down, but eventually over a period of time, all these 3 rates have gone down significantly, and we are now comparable to the NHSN standards in our rates of these 3 infections. Now, this was, of course, data which was very old because this was the first time we had done it, and which is why the result is pretty staggering. But for those of you all who have active infection control programs running, any intervention that you all do, you all may not get such good results because it's very difficult to improve once you start reaching close to 0. Okay, so this is briefly what infection prevention and control does, and the importance of infection prevention and control. So good infection control measures can reduce the healthcare associated infections by a significant number. Now let's look at how different or how similar are the IPC and the AMS programs. So both of them have different reporting structures. Now you have your clinical pharmacists who will be reporting to maybe the ID physician and maybe a medical director, and you have the infection prevention team which would report either to the medical director or, if it is kept under nursing, to the director of nursing services. So they're totally different. They look at different things. The aim of the CPs would be to minimize antimicrobial resistance, ensure that antibiotics are being used appropriately. Role of IP would be to ensure that infection control measures are followed, isolation precautions are followed, and so on. I think one common thing would be probably the policing part of it, which is done because both the CPs and the infection preventionists would often have to tell people something that they would not want to hear. So CPs may have to tell the doctors that the dose that you're giving this antibiotic in is not right. You may have to up it or lower it. You may have to stop this particular antibiotic. You're giving a double cover. You don't need the metronidazole when you're giving a meropenem, and so on. As far as infection prevention is concerned, it's usually about hand hygiene. Sir, please use the hand rub before you touch the patient, and so on. And usually there is maybe a moment's silence after this has been told. Eventually, people do come around to accepting what is being told because they do realize the value of what is being told. And they realize that this is nothing personal, but we are all doing it so that the patient gets better and goes on. Both are similar in the sense that they need to train healthcare workers on their areas of expertise. And the eventual aim of both is eventually patient betterment and ensuring that the patient goes home healthy and does not land up with an infection. So this is briefly the difference and the similarities in the functioning of the departments. Now, one point which is probably common to both is the trainings on sample collection, which is usually done by the infection preventionists and in some cases even by the CPs, where you would want to ensure the CPs probably would be looking at whether the culture has been sent before the antibiotic has been started. The IPs would probably be looking at how the sample is being collected. Again, have you collected it before antibiotics? Are you transporting it in time to the microbiology lab? Are the transport conditions proper? Has your requisition form been filled up properly? And I guess all these parts would probably be covered in the next lecture on diagnostic stewardship, which is a very interesting concept that is coming up. One thing I'd just briefly like to touch upon is the blood culture. Now, this is something that is an extremely important procedure for both infection prevention or microbiology and for the CPs, because an improperly collected blood culture will be detrimental to both, in the sense that you're going to land up putting a strain on the system and growing contaminants. You won't get the real pathogen, thereby patient won't get the correct antibiotics. So the amount of blood that you need, about 4 to 5, instead of 4 to 5 ml, you need about 15 to 20 ml of blood, preferably in 2 bottles, 2 separate pricks, sent in blood culture bottles, which then should not be refrigerated but transported in time. A proper disinfection of the skin before you collect it. and so on. So these are details probably which should be covered next, but this is something that is an extremely important area that all the CPs also need to concentrate on if they have not already started looking at it. So these are the differences and similarities between the IPC and the AMS. So far there has not been too much of an overlap. So let's just look at which area is going to overlap. So if you look at AMSP, main focus is minimizing resistance. So people will look at how antimicrobials are being used. For infection prevention, it is minimizing of HAIs or healthcare associated infections. So focus would be on bundles and hand hygiene. So one area of overlap that is going to come up in both these things is the multi-drug resistant organisms like Acinetobacter, MRSA, Candida auris especially, VREs and Clostridium difficile. So this is one place where both the CP, AMS and infection prevention has a role to play in minimizing the emergence and spread of these multi-drug resistant organisms. Now, antimicrobial resistance is a real problem, and there is enough data from various places, not just from abroad, but also from India. This is our susceptibility data all across isolates for 2019 in blue and 2020 in the orange. And if you can just look at the circled areas, you can see here that ceftazidime resistance sensitivity, has gone down significantly by almost 5% in the gap of only 1 year. Meropenem has gone down by about 3% in the gap of 1 year. Colistin has gone down from, it's no longer 100%. We have had issues with colistin resistance, and it is gradually going down. This resistance is not restricted only to the gram negatives. Our gram positives also have an issue. And you can see that with Banco and Tico, the last red circle that you see here, there's been a slight decrease. But over a period of time, now this is 2019, 2020. If I compare this with 2022, probably I might even see a further decline in the susceptibility trends. Now we all know this, we have seen this figure previously, the one at the bottom, where WHO has said that by 2050, the number of deaths caused by antimicrobial resistance is going to exceed that caused by other diseases like cancer and cholera, diabetes, and road traffic accidents, and so on. So we are looking at a big epidemic of antimicrobial, resistance. Now, previously we used to have an overlap between HAIs and antimicrobial resistance, but this was a small subset. The issue nowadays that we find is that these two circles are merging into each other, which means that we are getting more HAIs because of multi-drug resistant organisms. Now, if we just look at the Jahangir Hospital data again of last year of 2022, of the 41 odd isolates that we had got from the various HAIs that we had encountered throughout the whole year, about 26 of them were XDRs or pan-drug resistant organisms, and only 15 of them were non-XDRs. Now, there have been a lot of studies which have said that the mortality in XDR cases or PDR cases is more than those with non-XDR cases. Now, surprisingly, we have found a slightly different kind of a result, where when we looked at the 26 isolates which were XDR or PDR, we found that 19 of them were discharged and only 7 expired. So 27% was our mortality rate for the XDRs. Whereas if you looked at the non-MDRs, 9 of them were discharged and 6 of them expired, giving us almost a 35% mortality. Now, of course, we have not adjusted this for the other morbidity factors. This is just a crude mortality rate that we have tried to look at. But somewhere there is definitely, there is an increase in XDRs and PDRs causing HAIs, and there is possibly an increase in mortality also, but definitely an increase in morbidity. So cutting a long story short, multi-drug resistant organisms are a real problem. And this is where AMS and IC can actually work together to decrease this burden of antimicrobial resistance. So let's see how. Now, assume that this is a 4-bedded ICU and we've got one patient who's on antibiotics, whether rightly or wrongly is a matter for debate, whether it's use or abuse of antibiotics that causes resistance. But this patient develops multi-drug resistant Acinetobacter. Now, those 4 dots are supposed to be gram-negative Coccobacilli, which are suggestive of Acinetobacter. So one patient develops Acinetobacter, which is carbapenem resistant or XDR, sensitive only to colistin. Over a period of time, if you don't have good infection control measures, this Acinetobacter is going to spread to the remaining 3 beds also in that IC. So here you have a situation now where you have 4 patients with XDR Acinetobacters, and you can imagine the amount of colistin use or phosphomycin or minocycline or whatever you want to use, depending on the sensitivity, but the increase in the use of antibiotics that is going to happen in this particular ICU. So here is the role of AMSP where it comes in proper use of antibiotics to minimize this Acinetobacter from coming. If this Acinetobacter does not come up in the patient in the first place, there won't be any spread. So this is the role of the clinical pharmacist, where you're able to use antibiotics, ensure that antibiotics are used judiciously, no prolonged exposure of antibiotics, cut short the surgical prophylaxis at 1 day or maybe 2 days if required, but no excessive use of antibiotics. So this is where you try to prevent an MDR or an XDR from emerging. And if by chance that MDR XDR does emerge, here is the role of infection prevention and control, where it can prevent the spread of this MDR XDR to other patients. So this is where you're going to actually see a synergistic play of both these departments in ensuring control over an MDR or an XDR organism in a particular unit. So this is somewhat similar to the action of your cotrimoxazole in the metabolic pathway, where you have actions at 2 different levels and ensuring a good outcome for the patient. So this is the main role where AMS and IPC can definitely go hand in hand and definitely can make a big difference for the patient. Can we help each other in a different way? Definitely. There is a big role for a symbiotic association. One of them is the antibiotic monitoring form or the justification form, which I'm sure is being used in a lot of setups, where if you want to use any of the higher end antibiotics like colistin, meropenem, tigecycline, depending on what your policy, your institutional policy is, you need to justify why you want to use that antibiotic. So this is just to prevent the indiscriminate use of antibiotics. So you can imagine a situation where the CP goes into the ward and sees that, okay, a particular antibiotic monitoring form has not been put in. He or she can always tell the ICN in that particular ICU or room ward that, okay, this is what is lacking. This form has not been filled. So the CP may not be there all the time, but whenever the consultant comes in, if the ICN or the CP, whoever is there, can ask their consultant to ensure that this form is filled out. So here, instead of depending only on one person, you have multiple people on whom you can depend. Sample collection before cultures. I've mentioned this before briefly, but the importance of this cannot be stressed enough. The more people who actually stress on this, the better your cultures are, the better the quality of reporting, and the better the treatment that the patient gets. So this is one place where both can work together like a symphony. Then, of course, is the interaction for isolation precautions. The microbiology lab usually intimates the CP and the ID physician and the ICN that we have grown an MDR or an XDR organism, and you need to look at the antibiotic usage. You need to look at the barrier precautions. So here there could be an interaction between the two where, instead of it being micro to both these departments, there can be an interaction at their level as well, where they can call up each other and say that, okay, this XYZ patient from so-and-so the bed number is under barrier precautions or isolation precautions. So do you know about it? Has it come across to, so this kind of constant interaction is something that is extremely important. And of course, trainings on proper sample collection. How much ever you train the junior residents, the nurses, that training is insufficient when it comes to sample collection, because invariably they do the wrong method, or they they fail to instruct the patient appropriately on how to collect the samples. So these are a few places where both of them can work together, because this is something that is definitely going to be a win-win situation for both of them. So now that we've looked at an overlapping area for both of them, we feel that, okay, theoretically they can work together and we can get excellent results. Let's see if there's any data that proves it right or wrong. So this one good paper that was published in the IJMM in 2023 by Bansal et al., where they looked at an oncology center from North India, and they collected data from Jan 2016 to December 2021, and they analyzed the data in gaps of 6-month periods to make it a little more relevant. In 2016, they were already following the various infection prevention measures and the antimicrobial stewardship plans, but they just reinforced it. A few of the measures that they took was, first was they ensured that the blood culture, that was amount of blood that was sent in the blood culture bottles, was increased from 4 to 5 ml to about 15 to 20 ml. They ensured that paired blood cultures were sent instead of single blood cultures. They also asked the people to inoculate sterile fluids into blood culture bottles. This, in fact, actually increases the yield of pathogens, because many times these procedures are done in the night where your microlab may or may not be functioning. So just inoculating that synovial fluid or the CSF or whatever into a pediatric blood culture bottle and sending a little bit for microbiology investigations can actually increase your yield of organisms. Then they looked at making diagnostic facilities better, like making viral PCR available, galactomannan for fungal available. Infection prevention wise, they stressed on hand hygiene. They increased the availability of hand sanitizers. They kept hand rubs at every bed. They educated the doctors, nurses on healthcare, on device care bundles. They gave an audit and feedback system to all the healthcare workers who were there. So they made a slew of measures which were aimed at reinforcing both these programs. And they looked at the data in the beginning from Jan to June of 2016, and at the end of that period from July to December 2016. So they had some really stunning results. The VRE isolation rates decreased from 43.5% to 12.2%, which is something really great. Then the carbapenem resistant acinetobacters decreased from 66.6% to 17.02%. The XDRs decreased from 3.31 to 2.6 per 100 patients. The HAI rates, that is the CLABSI and the COTI, also decreased from 2.3 to 1.19. And they also followed up Candida from non-sterile sites, which decreased from 1.68 to 0.65 per 100 patients. So this was absolutely phenomenal. Well, they had some okay results as well, where they saw that the carbapenem resistance in pseudoaeruginosa decreased from 23 to 20%. The carbapenem resistance in E. coli went down marginally from 21.6 to 19.4%. And the invasive candidiasis rate was almost the same. But they also had a flip side. Everything is not rosy. Whenever you try to implement a slew of measures, you're going to get some good, some bad, and, well, some not so great at all. The carbapenem resistance in Klebsiella pneumoniae increased from 26.8 to 28.0%. And the most shocking, the colistin resistance increased from 0 isolates in the first part in 2016 to 43 isolates in the last 6 months of 2021. The VAEs increased from 7.4 to 9.7. So they were more pluses than minuses, but both were there. So this is something that is actual data that has been presented from a hospital. And I'm sure if you look at your own data, if you're able to collect and collate your data and analyze it, you all may find similar kind of results. So it appears that IPC and AMS can go hand in hand. Alone, we can do a lot, but together we can do much more. So I guess the verdict is, the decision is up to you all, whether I've been able to convince you all, whether IPC and AMS can go hand in hand. Thank you for giving me this opportunity to talk. Over to you, Alia.
Thank you, sir. That was really helpful. We really have a couple of questions.
Right.
Okay, the first question is, how can we be consistent with other healthcare staffs to follow basic infection control practices?
Okay. Very, 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 very difficult. There's a saying in Hindi, kutte ki dum, tedi ki tedi rehti hai. This is unfortunately something, a lot of infection control prevention measures, something simple like hand hygiene, often boil down to behavioral, behavioral issues rather than actually getting them to follow it. People know they're supposed to use hand rubs. People are aware that there is a hand rub bottle next to the bed, but still they will not use it. So somewhere I think this needs education on why they need to use a hand rub. Probably second, this is the first point. Second point is data on when you use a hand rub, what difference does it make? And third, constant reinforcement. You teach them something today, by tomorrow they would have forgotten about it. Hand rub being the first, because I think hand rub is like the alcohol hand rub, very volatile. It goes out of your brain immediately. So a constant reinforcement is required. And somewhere I think probably I'm not in favor of punitive action, but a rewarding, activity where if a particular ward is found to be compliant with more than say 95% compliance for hand hygiene, then they get some kind of an encouragement or a reward system. But this is something which is a challenge for all hospitals, irrespective of the class of people who use it. It could be doctors, it could be nurses, it could be HK, but it's a challenge across all the cadres. In fact, we found that HK people are more amenable to following hand hygiene than probably a lot of the doctors. So these 3 or 4 things: show them why they need to use hand rub, teach them how, show them where the alcohol bottle, hand rub bottle is kept, and keep hammering. These 4 things.
Thank you, sir. Next question is, how can clinical pharmacists have more role in infection prevention?
Okay. Like I mentioned before, there is an area of overlap. So, these are some areas where we need to work together. First and foremost, sample collection. Secondly, barrier precautions or isolation precautions wherever it's being followed. Usually what tends to happen is we've noticed this with hand hygiene again. I keep coming back to hand hygiene because we've done a lot of work in hand hygiene. Whenever the ICN is on her rounds, everybody reaches out for a hand rub bottle. The minute the ICN is out of the ward, nobody bothers taking alcohol hand rub. Now we have realized this because we have had secret audits being carried out or silent audits being carried out where a new intern who's joined and nobody knows her just goes around with a book and a pen and actually looks at how many people are using hand rub in the presence of ICN and without the ICN. So in addition to ICN, if a CP also does this task, then you have 2 people whom the people have to look out for ki hai ki nahi, and then use a hand rub. Sample collection is something which is extremely important. So if sample collection is being done, then the correct advice on how that sample is to be collected, most importantly, blood culture, because this is usually in ICU patients, and this will have the maximum impact on treatment for that patient. So the correct amount of blood to be collected, the proper disinfection of the site, and so on. And the other places probably where they can is an interaction of which patients are under MDR and so on. So I think these few places there is definitely a big role for the CPs to play in ensuring that infection prevention measures are followed.
Thank you, sir. I really hope that graph goes down by some miracle and that 2050 data won't come true.
I hope so too. But it's in our hands, whether we. I feel that at some point it's going to come in, but whether it's going to be 2050 or it's going to be 2150 is in our hands.
Yeah, that's true. Thank you for taking your time, sir. It really means a lot.
Thanks.
Thank you so much.
Thank you.
So we'll move on to our next speaker. Our next topic is diagnostic stewardship as a tool to reduce antibiotic use. And our speaker is Dr. V. Anil Kumar. He is a professor and head of Department of Clinical Microbiology at Ambedkar Institute of Medical Sciences, Kochi, Kerala. His area of interest includes diagnosis and treatment of infectious diseases, antimicrobial stewardship, infection control, etc. So he has a very high rate of publications, around 168, in which 56 national, 112 international publications, and he has around 6,200 citations. And he has hosted more than 134 lectures. So it's my pleasure to welcome you, sir. Over to you.
Okay, thank you. Thanks a lot for inviting. First, I would like to thank the organizers, especially Vrinda, for inviting me for this ECME and contributing. So, being a microbiologist, this is an apt topic for me to take because get involved in a lot of diagnostic stewardship activity in a hospital. And we've been doing the stewardship for quite some time. Vrinda has been with us for quite some time now, since the beginning, and we began with antimicrobial, and now we gone into diagnostic stewardship also. So I'll be talking about microbiological diagnostic stewardship. By definition, it means coordinated guidance and intervention to improve the appropriate use of the microbiological diagnostics to guide therapeutic decisions. Microbiological diagnostic assays mostly lead to change in antibiotics or initiation in antibiotics. So it has a big implication in your AMR and antimicrobial use. That's the reason diagnostic stewardship in microbiology is so important. So basically, it means timely diagnostic test. Timely diagnostic testing would include proper collection, transport, processing, identification, and then releasing the report on time so that it makes a difference in the patient's treatment protocol. By default, everybody believes that diagnostic stewardship would lead to cost saving to the patient. Now, it depends on where you are doing a diagnostic stewardship. If you go to developed countries like US and European Union, yeah, diagnostic stewardship will reduce the cost to some extent because the diagnostic assays used in those countries are very expensive, very high end. But when you come to developing countries like India, where we don't have a very high-end diagnostic assays available readily, and labs are not that sophisticated, not automated, diagnostic stewardship will actually increase the cost because we would like to have a better diagnostic assay than the existing ones. So it depends on where we apply the diagnostic stewardship, but it doesn't have anything to do with the cost. Diagnostic stewardship means value. We want to produce value by using that diagnostic test, whether it's cheap or whether it's expensive. So it doesn't matter what type of test it is. We would like to make sure that it makes good sense to use that test and make difference to the patient. So the two objectives of diagnostic stewardship is to deliver safe and effective treatment. And we also would like to collect the data on antimicrobial resistance. These data can be collated together to form treatment guidelines to develop strategies to control AMR. So that is the two main objectives of doing a diagnostic stewardship. So usually the flow of the diagnostic assay and the report is between the clinical team and the laboratory team. The clinical team assesses the patient, writes a diagnostic essay, then sends a sample, laboratory does the test and reports to the clinical team. So that's how it works everywhere in all the hospitals. But stewardship, when you put stewardship in place, you will have to have a team that will collect this data also. These data on antimicrobial resistance, specimens, everything, and collate together. So there are databases, national databases, where they take up the resistance data. The ICMR is collating the resistance data from different centers all over the India, and they come up with the national antibiogram every year nowadays. And there is a state database also in Kerala where they collect the antimicrobial resistance patterns in different hospitals. So these data can be then used to make a local antibiogram, a national antibiogram, frame empirical treatment guidelines, and also frame strategies to reduce AMR. So this is the reason that surveillance needs to be done simultaneously along with diagnostic assays. So where does the diagnostic assays go wrong? Where is the error? So it may be delayed diagnosis, it could be over-diagnosis, it could be misdiagnosis. Most of the diagnostic errors occur in the lab where it's analytic. The testing being done and something goes wrong with the testing or reporting, it's analytical. So most of the errors, at least 44% of the errors occur in the lab. 32% takes place in the clinical end, the pre-analytic area where the clinician decides which assays to be ordered. Or the clinician, then they take up the wrong specimen, the specimen is collected in the wrong way, it gets contaminated. So many issues takes place in the pre-analytic area. So the second most common area of getting an error is due to the pre-analytic reasons. So why diagnostic stewardship? We already have antimicrobial stewardship, we have infection control. So why diagnostic stewardship? The reason being that just by modifying a test assay, we can impact a large population. Large population means whoever we are catering to. My microbiology lab caters to some 1,200 patients in this hospital. And all the clinicians have to go through my microbiology lab. So if I change a policy here, everybody is impacted. So you actually don't need to go and catch hold of the individual physician, train them. So that is a big headache for antimicrobial stewardship to approach the clinicians and teach them, tell them. They won't take it in the right way also, and they may not have the time to listen to us. When you change the policy, everything is affected, and you also rely on quality indicators. Quality indicators like collection, transport, contamination, labeling, everything is taken care of, and all these contribute to the diagnostic stewardship program. So you don't have much hard work to do to implement diagnostic stewardship. So you need a very dedicated person in the lab who wants to bring about stewardship and makes policy changes with the approval of the administration and the doctors, the stakeholders, and then implements in the hospital. So why do we need it? Because most of the assays in microbiology is being prescribed without any specific signs and symptoms. So the disease process may not be specific to that particular assay. For example, the pre-test likelihood is very low. That is, when you order a test, the likelihood of coming in positive is very low. So don't order such tests. Like urine cultures being ordered without any symptom. Most often, just because the patient is spiking fever, you order a urine test, urine culture. The Clostridium difficile assay is being ordered without diarrhea. The patient just said that he has passed loose stool, and immediately you order a Clostridium difficile assay. And blood cultures being ordered for any patient who enters the ER. So when you order such tests rapidly without any reason, the more number of tests you order, more number of false positives. False positives are due to the commensal flora, contaminants, colonizers, and ultimately you end up giving a lot of antibiotics. Antibiotic resistance is increased, and adverse events due to the drug also increases. So it's directly proportional to the use of antibiotics. So this happens because of wrong ordering of the test without signs and symptoms. And moreover, as of now, diagnostic assays in microbiology does not contribute to a big chunk of the cost of the patient. It's only 4% of the healthcare cost. But gradually, as you have seen, we have discussed BioFire in the first lecture. These assays are very costly. So multiplex PCR panels are coming, many new assays are coming, which are very costly. So gradually, the cost of microbiological diagnosis will go up and contribute a large chunk to the cost of the patient. And almost 20% of the test is overused or underused. As a result, you have a delayed or incorrect diagnosis, which results to inappropriate treatment, which may result to adverse patient reactions or adverse events in the patient, antimicrobial resistance, cost increases, patient stay increases. So all these things happen because of inappropriate use of a microbiological assay. So what is the benefit of doing a diagnostic stewardship? It improves the accuracy of the diagnosis. The moment the diagnosis is accurate, everything falls in line. You have an appropriate treatment. You have more number of true positives, less number of false positives, less adverse events, less the length of stay of the hospital. And actually, it can bring down your hospital infection rates. If you follow the diagnostic stewardship, your infection rates will go down because most of the tests are ordered without any signs and symptoms, come positive because of contaminants or colonizers. So we have to keep in mind that we should not go overboard in doing diagnostic stewardship. We want to change the whole system. We want to drastically reduce the urine cultures, or we want to drastically increase the blood cultures. We want to send multiple blood cultures. So you should understand that by implementing this, it should not harm a patient. We should not miss a single case of UTI. We should not miss a single case of Clostridium difficile that was a genuine case, or we should not miss a single case of sepsis. So diagnostic stewardship should be implemented after giving a serious thought and discussing with the stakeholders, or the stakeholders will blame you for missing diagnosis. So you have to take this into account when implementing a diagnostic stewardship. So diagnostic stewardship can be in 3 stages: pre-analytic, analytic, and post-analytic. There are 3 stages of testing. Pre-analytic means ordering, analytic means doing the test, post-analytic means reporting and what happens with the report. So the first is your pre-analytic. Pre-analytic, what you can do is you have to collect the specimen only when the case definition is fulfilled. For this, you have to come up with a case definition for UTI or CDI, Clostridium difficile infection, or sepsis. So once the case definition is fulfilled, only then you collect an appropriate specimen. That is the correct specimen. You send urine if it's UTI. You don't send urine because it's just because of the fever. You send you appropriately collect the specimen. You collect the specimen with sterile precautions, like you collect a blood culture after doing all the disinfection procedure, and then allowing it to dry. Only then you draw the blood, and you draw the blood from two different sides. You set two sets of blood culture bottles. So the appropriate collection should happen, and whatever is collected should reach the lab within 2 hours without delay. And the most important part is you have to provide a complete clinical, demographic, and epidemiological information wherever relevant, along with the patient specimen, so that we can make sense of what has come to the lab and how to proceed and what to look for. Now, this is an example of pre-analytic intervention in urine culture. This is a study which has been published in JAMA, and you see what they did is they intervened with the urine cultures. They did the intervention that you have to send urine only if it fulfills the IDSA criteria of UTI. You audit them, provide them the feedback, you do case-based presentation with the clinicians, and ultimately what happened that after intervention, the urine cultures drastically reduced. Only the relevant ones was being sent, the unwanted ones stopped, because you have to fulfill the definition, and then only you send the urine cultures. So this reduced the number of urine cultures, this reduced the number of asymptomatic bacteriuria that was being diagnosed. It reduced from 1.6 to 0.6. That's a huge difference, 1.6 to 0.6 per 1,000 bed days. So this is a diagnostic stewardship intervention, pre-analytic intervention in urine cultures. Now you see, this is for respiratory specimens. This is a diagnostic stewardship intervention in community-acquired pneumonia patients who get admitted in the ER or the hospital. So most often the nasopharyngeal specimens are being sent. Second is the pharyngeal specimen. So what happens is this blue chunk you see is negative test. So most of the tests come negative, and the yield actually is only 24%. In case of pharyngeal secretions also, the huge chunk of specimens are negative because the specimen is not that great. So the diagnostic stewardship intervention was to send only expectorated sputum or induced sputum. That is a very high quality specimen. The moment you send expectorated and induced sputum, the number of specimens also reduced, the number of negatives also reduced, and the diagnostic yield was twice, 51.7%. So just by a diagnostic stewardship intervention of improving the sample quality for respiratory secretions, this was a huge jump in the yield, as well as unnecessary tests being avoided. So this is how the pre-analytic diagnostic stewardship for respiratory specimens. Now let's have a look at C. difficile. Now, hospitalized patients having diarrhea, one episode of diarrhea, many people will send a C. difficile. So 20% of the hospitalized patients are colonized without any problem. They don't have any symptoms. They are just colonized with C. difficile. If you send C. difficile testing for every flimsy lesion, any bowel movement, you will get many positives. Only 1 to 2% of the patient are actually having the disease. So if you send testings which are very sensitive, like a PCR, a CARBA testing, like a gene expert testing for Clostridium difficile, it may come positive for toxin, which is a colonizer. It may come toxin negative, a PCR positive that indicates it is a non-toxinic strain that is there. So it creates a lot of confusion in the doctor. What is it? So don't order a test just because you want to order it. C. difficile protocol is that the patient has to be hospitalized for 72 hours. Any diarrhea in less than 72 hours may be community acquired, not a C. difficile. So 72 hours of admission, you have the risk factors for C. difficile diarrhea, that is, has got a broad spectrum antibiotics being given for quite some time. And then you define diarrhea. Diarrhea is more than 3 watery stools in 24-hour time. No less than 3 watery stools is not diarrhea. So just don't send a sample for less than 3. So you fulfill the case definition, and then you find out why the diarrhea is occurring. Do you have an alternate reason for diarrhea? That is, whether the patient is having a laxative, very commonly used in hospital, whether the patient has taken oral contrast for some procedure. If that is the case, then diarrhea will happen. It is not a C. difficile diarrhea. So once this is also fulfilled, then you find out whether C. difficile was sent in the last 7 days. If yes, don't send the specimen, because there is no test of cure. Once it is positive, you don't have to send it again to see whether the infection has been cured. It will still come positive because some bacilli will be still there. So all these conditions are fulfilled, then only send a C. difficile PCR for the C. difficile PCR to the microbiology department. Otherwise, don't send a C. difficile for your patient just because he had 1 episode or 2 episodes of bowel movements, which can be explained for other reasons. So this is another diagnostic stewardship, pre-analytic. Now, what is analytic? Analytic means microbiology. Microbiology should be 24/7 lab, should have acceptable amount of automation. Most microbiology lab do not have an automated blood culture, automated ID/AST. Only the tier 1 cities have got, but metros have got, some tier 2 cities may have, but most of the labs may not have an automation because it's expensive. Should offer a wide array of infectious markers, should be accredited by NABL or any other authority, should have EQUAS, that is quality control assays should be done, and then should follow the latest ESG guidelines. The CLSI guidelines come, they will get revised every year. The important changes should be highlighted and should be implemented. And foremost, you have to have a clinical microbiologist to make sense of what the test is being done, what the report is being released. So then only you have an analytic. That's a major part of analytic stewardship, diagnostic stewardship in microbiology. So interventions, what you can do, once you have a good lab, a clinical microbiologist, everything in place, then you can do an analytic stewardship. Yes, that is, I'm giving an example of 3 where urine cultures can be reflex-free cultured, that is only pyuria would be cultured. C. difficile testing would be done only when specific criteria is met, and blood cultures, you can improve the reporting time in blood cultures by introducing certain new assays or rapid assays. Let's look at them one by one. So reflex urine cultures is that you have a lot of urine cultures. The most amount of specimen that comes in my lab is urine. So you don't need to culture all of them because most of them may not have a symptom. So what you can do is you can culture only urine specimens which have more than 10 WBCs per hyper. If you don't have 10 pus cells, you reject the cultures. You don't proceed with the cultures. So what is ultimate results is fewer cultures, fewer bacteria rates, and fewer antibiotic starts for bacteriuria. So that's a very good method of doing a diagnostic stewardship analytic in the lab by reducing unwanted urine cultures. Now look at this gentleman who is an elderly patient who comes from comes to the hospital with UTI. He has a catheter and he has got only symptom is altered mental status, and he has recently started a beta blocker. So this urine was sent, urine was clear, there was no specific urinary symptoms, suprapubic tenderness was not sent. Urine analysis showed only 3 WBCs. Culture was not performed because it didn't meet the protocol. The delirium was explained by the new beta blocker that was included. The patient was given discontinued beta blocker. He recovered and he went back. So what happens if you culture that urine? You don't have a stewardship, diagnostic stewardship. You culture a urine from a catheter, it will grow lots of bacteria. E. coli was grown in significant amount. It was you started treating the ESBL, the delirium worsened. He developed diarrhea. C. difficile PCR was positive. Then fever, tachycardia, hypotension. The patient goes into sepsis, acute respiratory failure, prolonged stay. So that is what happens if you do a wrong culture, give a colonizer, and you treat a colonizer. Everything goes down the drain. So that is where the diagnostic stewardship will help the patient. So the problem is urine culture is that it is not midstream, it's contaminated, collection site and catheter is not mentioned, collection from urobag may happen, delay in transport, ordered for all patients with fever. They want to blame the fever to the urine without any reason. And signs and symptoms never mentioned. Now look at the C. difficile diagnostic stewardship or analytic stewardship that you can do. So when a stool sample comes for C. difficile in microbiology lab, we can do electronic data, check the electronic data of the patient in the HIS, the hospital information system, and find out whether the patient had 3 episodes of diarrhea, if possible. If the patient had tested in last 7 days, if the patient had laxatives, you can see the drug chart and see whether the patient had laxative in the last preceding 48 hours. And if the sample is not received within 24 hours of ordering a test, you reject the sample. So all these criteria are not met, you reject the sample. And when the stool comes in your lab, just look at the stool. It should be watery without no solid pieces. That is Bristol stool chart type 7 type of stool, type 7 stool. If it's having solid particles, then it is rejected because it is not watery, it is not severe diarrhea. So you reject these samples. What happened? The Stanford experience shows that 9.1% samples orders were cancelled because they received laxative. 7% were cancelled because there was no diarrhea in the first place. Stool was semi-formed or well-formed or hard. And C. difficile test utilization decreased from 208 to 143. Hospital onset C. difficile incidence reduced from 13%. So you are reducing the HAI rates, 13 cases to 9.7 cases. Oral vancomycin decreased from 13.8 days to 9.4 days by just looking at this tool, checking for laxative, you could reduce I produce so much impact. You just reject the sample in the lab itself. Now, let's see the blood culture. Blood culture, the standard is you should have an automated blood culture. Very few labs must be having it. You should have an automated ID and susceptibility testing, which helps a lot in getting a proper, robust report without contamination with relevant parameters. But still, you have a 72 hours gap to get the ID and susceptibility from a blood culture. A blood culture flags positive in 15 to 20 hours. You require 18 to 20 hours to grow the organism, another 18 to 24 hours with susceptibility and ID. So what can we do to improve this? You can add technology to it. We have listened to the previous speakers where they have said that they introduce a film array BCID panel here. The moment the blood culture comes positive, a film array is done, tells you the organism, tells you the mechanism of resistance for ESBL and carbapenem, and you can do we can give an appropriate treatment within 2-3 hours of blood culture coming positive. If communicated as fast as possible, you can do it. You can also do a MALDI-TOF if you don't have a biofire and get an idea of the organism the moment the organism grows. So these things can be implemented, but you should understand that this is additional cost. The cost of blood culture would increase significantly. Each assay in biofire would cost 15,000 rupees. That is a huge amount. This instrument will cost you 1 crore. So who will buy a 1 crore instrument to the microbiology lab? So these things should be taken into account. So diagnostic stewardship to improve the yield of blood culture and reporting as much as possible would increase the cost of testing and treatment. But if you see in the long run, the antibiotic de-escalation or antibiotic no use, not being used, it may benefit, it should benefit the patient and the hospital and the patient getting discharged as soon as possible. Now, we can also go for a lesser stewardship where you can look at the normal flow. You should be having a 24/7 microbiology lab because the blood cultures can come positive in the middle of the night. It should be immediately pulled, done a gram stain, and the gram stain should be immediately reported to the clinician as well as prioritized to be tested there itself if the growth is there. So these things that doesn't happen in normal labs because they are not 24/7. In the night, the staff is very lax. So all these things, if you improve, you can improve the reporting and improve diagnostics towards improve the outcome of the patient. But just by implementing few changes in the normal workflow, prioritizing organism, etc., you can do it. Not by buying new instruments. So these things also can be done. So when you're doing a multiplex PCR assay, you should understand that pre-test probability should be for at least 2 organisms in that panel. You should have a high pre-test probability of at least picking up 2 organisms in that panel. You should collect the specimens in the way they recommend. It should be properly collected, transported without contamination because the PCR assays are very, very sensitive. It will pick up bits and pieces of DNA in it and it will tell you that it is positive. Analytic in the lab, it should be handled, sample should be handled very carefully, processed very carefully to not cause contamination while doing this. Post-analytic PCR assays will flag many things positive. So there should be somebody to give some comments, make sense of what is being reported, how it is being reported, whether we need to report. Like C. difficile by default comes in the GI panel, but you don't need to report C. difficile in any patient who is having a community-acquired diarrhea, only to be reported in hospital-acquired, hospital-onset diarrhea. So they have shown that BCID panel or multiplex PCR panels included in the blood cultures flow would reduce the time to initiate appropriate therapy, reduce the length of stay, reduce mortality, but only with antimicrobial stewardship. The reports should be conveyed to the stewardship team. The stewardship team, the ID physician or the clinical pharmacist should take the decision what to do, convey it to the treating physician and make difference. Without stewardship, it doesn't reduce the mortality significantly. So we need a stewardship team to work hand in hand with the microbiology lab in making sense of these high-end tests that we are going to introduce as part of diagnostic stewardship. So what is the problem with blood cultures? Lack of automation, low blood volume. People send only 4 to 5 ml of blood, 10 ml of blood minimum in each bottle from an adult. Not ordered, underutilized, only 1 bottle is being sent. Single blood cultures, not great. High rates of contamination. Collection is not proper. You get a lot of contamination and the whole purpose is lost. The money is lost. Everything is lost. Lack of 24/7 blood culture processing and reporting. This is mandatory if you have an automated blood culture. You have to have 24/7 because automated blood culture gives you the benefit of automatically knowing which is positive. So there should be a person 24/7 to pull it out and make sense of it. Otherwise, it beats the purpose of keeping an automated blood culture system. Cost is high because of automation. Post-analytic intervention is you combine stewardship with the reports. You selectively report antibiotic or you give comments along with the reports. Like it is a commensal, it may not be needed treatment. The colony forming unit is less, so it would be only treat if the patient is symptomatic, so on and so forth. So one is you cascade form of reporting. You report only antibiotics that is relevant, the first line, second line, or third line, whichever is relevant, because if first line is sensitive, you don't report. The second line is sensitive, you don't report. Third line. So this helps the prescribers, the end users, the doctors to more adhere to the guidelines. Also, it changes the prescribing behavior. So just by modifying the number of antibiotics we are reporting, we impact a large population, improve compliance. So this particular study showed how the compliance improved. Compliance to guidelines improved from 14% to 56% just by reporting only selected antibiotics, which were in a cascade fashion. That is, they didn't report higher antibiotics, reported higher antibiotics only when the first line or second line were resistant. So blood culture gets contaminated very often. You should understand all bacteria are pathogenic except for few like these. Coagulase negative staph, Corynebacterium, Bacillus, if grown in blood culture bottles, are always a contaminant. You should understand they are significant only if two blood cultures are sent from two different sites drawn on two separate occasions within 2 days of each other. So two blood cultures from two different sites within 2 days of each other. If both of the blood culture bottles flag positive for a contaminant or a commensal, it is considered to be significant, go ahead and treat it. So what is the low-hanging fruits? How will you implement diagnostic stewardship? Urine cultures, you send less often urine cultures, you send only when the symptoms are there. Blood cultures, you send more often, send multiple sets of blood cultures and try to collect it without contamination. Sputum ET aspirate cultures, less often. We don't require unless and until there is a pneumonia. Try to send a good sample, that is an expectorant sample or reduced sample. Swabs are never good for cultures. Always send aspirates or tissue bits. You'll be very happy to process them. Swabs are least sensitive. The viability is lost. It becomes dry. Relevant and restricted reporting of antibiotics will create immense impact in the prescribing behavior and adherence to guidelines in the clinicians. So what the organization should do, set up a good microbiology lab, set an epidemiological and data management capacity, have an infection control team coming in for the AMR and collecting data, assess the implementation, where all we can implement, which are the, I told you the low hanging fruits, you can implement any one of them, provide budget, resources, and roles and responsibilities are fixed. Clinical staff is meant to do the pre and post analytic stewardship. Microbiological staff does the analytic, post analytic part of the diagnostic stewardship, and the ICT team take care of the surveillance, that they capture the MDR rates, the CRE rates, etc. Communicate this to the clinicians that you are implementing this particular protocol and you'll be rejecting samples if these criteria are not met. Train them, train the people how to collect samples, train the staff how to reject samples, evaluate, monitor, and find whether it makes sense, whether it's improving, and pass on this message to all the stakeholders that after implementation, we have improved so much, we have made a big difference in antibiotic consumption, AMR rates, or so on and so forth. So diagnostic stewardship in Amrita, a few bits of background I would like to mention. Blood cultures, if it grows gram-positive bacilli, it's usually a contaminant, but we always do an AFB screening because we have a huge population with PICC lines where rapid growers or mycobacteria, non-tuberculous mycobacteria is seen in blood cultures. So we don't want to miss it because you have to remove their line immediately the moment you find a rapid grower growing in a blood culture. Urine cultures and sputum cultures, if they are contaminated, we ask them to send a repeat sample. We'll do a repeat sample. We'll reject that sample. Monthly audit of high, this is a quality indicator program that part of the NABH. The high contamination rates, we check which units are having high contamination of the blood and urine, and we do an intervention, train them and inform them. Restricted reporting of antibiotics is always practiced. We improve panels. TB panel. Now, people used to miss culture, people used to miss CB-NATs or smear. So we created a panel. So there is no confusion. The moment you order TB panel, by default, smear, culture, and CB-NAT is ordered by default. So you just have to send a specimen and order TB panel, nothing gets missed. Similarly, microbacteritis panel was implemented so that nobody misses any part of the test. And we introduced a checklist for microbiological samples, especially this particular checklist where we have, it's easy for them to tick what is present in case of UTI, what is the sample, where from, and what are the symptoms. In case of central line, blood cultures where the central line is present, specimen, In case of any other specimen, what is the symptom, what is the reason why they are sending, just columns for them to write, so that we have a good idea of what they are sending and why they are sending for. So diagnostic stewardship, to sum up, means right test, right patient, right time. And it is not having anything to do with the cost. It depends on where you are implementing diagnostic stewardship. If it's a developing country, cost is going to increase. If it's a developed country, cost is going to go down. If you're accredited, these things come by default because it's part and parcel of the accreditation process. So we all know what test the doctors and everybody know the test availability and what test, but we all should, wisdom lies in knowing where to implement this test. So diagnostic stewardship is where to implement this test and how to make sense of this test when the report comes. Thank you.
Thank you, sir. That was really helpful. We received a few questions. First one is, how can the organization convince the consultants to follow proper diagnostic stewardship?
Pardon me?
How the organization can convince consultants or physicians to follow proper diagnostic stewardship?
See, the diagnostic stewardship is that you don't have to teach the physicians too much. Diagnostic stewardship, we have evidence that diarrhea is 3 stools in 24 hours. Go and implement it. There is evidence that that is diarrhea. That diarrhea, C. difficile diarrhea, is more than 72 hours of hospitalization. With risk factors, if patients have the diarrhea test is being done, C. difficile test is being done without fulfilling this criteria, you have the right to reject it. You can implement that signs and symptoms are not being mentioned. Catheter is not being mentioned. The specimen is contaminated. It's a salivary specimen. It's a watery specimen. You can reject. So you don't need to, you have to just convince the administration. You don't need to convince the doctors. You have the evidence that this is a contaminated sample and it will grow things that is not relevant. And if the clinician objects, then you have to go and talk to them, give them evidence and show them this is the reason we are doing it. There is a scientific basis for doing it. But if you are not having a scientific basis, then it becomes a problem. Then you have to talk to the clinician and find out what, because there are certain areas, certain surgeons will not accept it. Like my particular surgeon says that you grow anything from the urine, you have to report. Otherwise, I will not accept it. So those cases we have to make for the special case, that pediatric surgery. If the sample comes, we report everything. Urology sample comes, we report everything. But we have to take it with a pinch of salt because we can't help it because the doctor wants it. They have their own reason. They say that my patient is an OPD patient. We can't come again and give the sample. You have to give the report. They see the report only after 3 days when the report is released, when the patient comes for follow-up. So those things we have to make an exception if the clinical team is not that, is not accepting our rejection criteria there. Otherwise, universally we can implement if you have the evidence, show it to the administration, get an administrative approval and go ahead and do it.
Okay, sir. Thank you. Next one is, how can clinical pharmacists help consultants or physicians in diagnostic stewardship?
The clinical pharmacists have a big role in the sense that they can tell the patients that this is the reason why it's happening. Now, you are there in the rounds along with the clinicians and you see that this particular patient sample has been rejected. Then you can tell this particular patient had a laxative that he was having diarrhea. That's why the microbiology didn't accept it, didn't test it. Or this particular urine is growing more than 3 organisms, so there's contamination. That's why it has been rejected. So these things you can get the rejection criteria, the diagnostic stewardship criteria that the microbiology practices and convey to the clinician during rounds to tell them that this is what has happened. So that's the way clinical pharmacists can guide them, or they can also guide them during sample collection if they are around. If somebody is ordering a C. difficile, you can check whether these criteria are being fulfilled or not, and tell them immediately that these criteria are not being met, so don't need to send a sample for this particular assay. Don't send a urine just because the patient is having a cloudy urine, a foul-smelling urine. It is not, and even pyuria in a catheterized patient is not UTI. So you can tell them that there itself in the ICU that don't send this urine for culture. doesn't make any sense. If you want to send, check for the symptoms, put a new catheter, draw urine and see. So these things, if you know, you can educate the and stakeholders there in collecting, transporting, and ordering the test.
I think that's it, sir. There are no more questions. Thank you so much for taking your time and presenting it for us.
Okay, thanks a lot.
Really appreciate it.
Contributing to the cause.
Thank you so much, sir. So before we conclude, I would like to inform about tomorrow's schedule. Tomorrow is day 3 of our ID week, and the session theme is challenging ID cases. How can it get more complicated? So we have our speakers, Dr. Parikshit Prayag and Dr. Neeraj Siddhar, Dr. Rajesh Soman. So that is tomorrow's topic. So participants, you'll be receiving a feedback form to your email. So make sure you submit that to download your certificate, and separate certificates will be issued for each day and not one for aggregate. That's it. Thank you so much.